to present to you will be published in Annals of Surgery. It's pretty much an automatic publication. It's pretty much already been accepted. So let me show you what I got here. You can see that screen.
Yep.
Okay. And there you go. Okay. And I'm going to pop you down here so I can see my screen. So this was my first slide, which is good because, you know, I tried to get a little plug in there when I started. And I started out with this first slide, which said, despite all measures that we're doing now, mandated across medical centers, surgical site infections remain a clear and present danger to patients, and they're inclusive of superficial site infections, deep infections, organ space, and anastomotic leak. And the presumptive etiology is that this is due to a breach in sterile technique or some type of intraoperative contamination event. Therefore, all current and future recommendations are more sterility measures and broader antibiotic coverage. The problem is these are not evolutionarily stable strategies. This is a line I got out of this book written by one of the world's foremost evolutionary biologists. And we're starting to see the ravages of this problem, which are today, it's estimated that more than half of the pathogens causing surgical site infections are resistant to the standard prophylactic antibiotics used in the United States. And the problem is that evidence does not support the claim that the majority of SSIs are due to an intraoperative contamination event. And I examined this in depth for all the available evidence, and it turns out there's a paradox. In the majority of cases, routine wound cultures from the operative field during surgery do not match the pathogens cultured from the SSI. And in the words of Neil Hyman, who's on our scientific advisory board, he says, if direct bacterial contamination is the cause of most SSIs, why then can you create a colostomy and not cause an SSI all the time? It's kind of an interesting and provocative question. So
it is, and I like how his role is curmudgeon.
yeah, he was there and he liked that term, curmudgeon. So one way to explain this paradox is to say that clinical infection is dependent on a series of complex molecular interactions, not a one-time contamination event. Operative trauma causes cues to be released by those tissues. They're taken up by bacteria. Bacteria feed back on the host in what's called a bidirectional interkingdom signal exchange. Bacteria also do this because they exist in colonies, not as single bacteria, and you end up with a matchless web of dense dynamic interactions that are unique to and dependent on the environmental context. And that's why virulence, harmfulness, or actual clinical infection is neither a sole property of the pathogen nor that of the host. Rather, it is a property of their interaction.
This, how you just described that, is everyone who's doing microbiome or AMR needs to hear it like that. That's great. That last slide, I hope we have it recorded because that's great.
Good. So one way to explain the paradox is this paradox that we see here, is that bacterial activating cues, not bacterial contamination itself, predicts vulnerability to infection. Of course, you can't have a wound infection without bacteria, but bacteria alone are not sufficient to cause a wound infection. So you might ask, if not from intraoperative contamination, then how? Well, we came up with this Trojan horse hypothesis when we noticed, as you can see by that scanning electron microscopy on the left there, we noticed in mice receiving antibiotics that there were packets of bacteria stuck deep in their crypts that could be taken up by immune cells, neutrophils or macrophages that silently home postoperatively to wound sites where they release their infectious payload. And clinical infection occurs depending on the presence of bacterial activating cues all along this journey. So Monica Krazelek, who is a resident in our program, spent 2 years in my lab. She's now a colorectal surgeon. She did this study where she gavaged down MRSA into mice and documented each and every one of those steps along that journey in dense molecular detail. And that study's been followed up by a second study done by another lab showing exactly the same thing using exactly the same methodology as we did, only in an orthopedic model. So the hypothesis of this study is that gut microbiota play an unappreciated and causative role in SSI pathogenesis beyond direct contamination and can be manipulated to reduce surgical site infections by doping the intestine with phosphate. Now, why phosphate? Well, because phosphate is essential for the growth and fitness of all life on Earth. In fact, when we operate on patients, we deplete gut mucosal phosphate by releasing phosphatonins, which increase the renal excretion of phosphate. And this occurs in a way that is not reflected in the serum phosphate level, and it cannot simply be repleted with IV or pure inorganic phosphate. And during health, intestinal bacteria forage through and feed on phosphate-rich mucus. And you have three effects: a surgery effect, which depletes the mucosal layer immediately; a diet effect, animals that eat a fiber-free diet, or humans, deplete their mucosal phosphate, their mucus; and an antibiotic effect. If you wipe out the normal microbiota, they are what drive MUC2 expression and actually drive mucus production. And now these proliferating bacteria have no choice but to get their phosphate from intracellular stores as ATP or in DNA. And bacteria have evolved highly conserved phosphate sensing and seeking mechanisms that directly link to quorum sensing. So when phosphate is abundant, this renders pathogens insensate to these incoming activating cues. So we wanted to develop a mouse model in which SSIs develop spontaneously from indigenous gut-derived pathogens and then dope the gut with phosphate to prevent SSIs. To do this, we had to have those three elements: a Western diet. Then we gave the animals antibiotics before and afterwards. And then we created a sterile surgery by cutting the back skin, exposing the underlying muscle, burning it in 6 spots with a cautery, and then placing a fluorosilk suture, closing it, putting a tegderm on it, and then sacrificing the animals 10 days later. And note, there's no bacterial growth at the time of closure. This is not due to intraoperative contamination. And here are the results. In the chow-fed groups, you can see there's negligible infection rates, but it's mostly staph when there was an occasional animal that got infected. If you give them the antibiotics, which get rid of the staph, now you have a polymicrobial infection. It's still a low incidence infection. Now, let's give them a Western diet, and you can see right away that there's a greater chance of getting a clinical infection, and I'll explain that in a minute. And if you give them antibiotics, you have the worst infections with these bacteria, which you would say, aha, those are from the gut. You must have opened up the gut and spilled it on there. We did not. They were sterile when we closed. And if you look at the 16S rRNA, the genetic sequencing, and the amplicon sequence variants, which is exact sequence variants, tells you what strain came from where. The strains from the gut and the wound are genetically similar. So let's dope the gut with phosphate and see if we can prevent this problem now that we have the model. So this is Covera's proprietary compound. At the University of Chicago, we de novo synthesized a phosphorylated triblock copolymer that has these properties. The aromatic ring locks onto the membranes and keeps that phosphate and polymer on the mucosal surface. And it's tasteless, odorless, well-tolerated, non-diarrheagenic, and distributes down the entire rodent GI tract. And it binds to lipid rafts. And it's PI-PEG, it's high molecular weight, phosphorylated polyethylene glycol with the right amount of phosphate on it that won't break off and get absorbed. And it acts as a surrogate mucin so that it has all the right chemical properties so that it interferes with these interactions. And it does this without affecting bacterial growth. So now we spike the drinking water of these animals and perform reiterative studies in that wound model and looking at the gut and wound microbiome. And right off the bat, you can see that mice whose water is spiked with PI-PEG culture negative. They don't grow anything. But we wanted an infection that is meaningful to surgeons. We wanted grossly visible pus, inflammation, dehiscence, and a positive culture. And so we called that the clinical microbial wound infection score. And you can see right off the bat that mice drinking PI-PEG do not develop clinically meaningful SSIs, similar to untreated chow-fed mice. Now, this PEG protects against these wound infections by modulating the microbiota. So here you can see in the Western diet plus antibiotic group, you have an overgrowth of gamma protobacteria. These are gram-negative bacteria. And you have a depletion of the Bacteroidetes and the firmicutes. Not the case in these groups, especially the group drinking PI-PEG. You now see suppression of the gamma protobacteria. Why? Because you have overgrowth of these friends with benefits, Bacteroidetes and firmicutes, which are now suppressing. That's enhancing the normal microbiota. And when you look at ASV dominance, and this is again exact sequence variants, you can see that what was in the cecum is what was in the wound, including staph. Now, I can't tell you that the staph came from the gut. I can only tell you that the staph in the gut and the proteus and the Bacteroidetes, et cetera, were genetically very similar at the strain level. Now, if you're still not a believer, we did this, and Monica Krasilek had done this in the previous study, where we took the 3 most common bacteria, and I said, okay, redo the experimental platform, and then swab that wound postoperatively with the 3 bacteria at 10 to the 7, which is a huge dose. And we did that every day for 3 days after we closed the wound. And there was no infection in the majority of the mice. 80% had no infection at all. 2 outliers. But if you look at Western diet and antibiotics, you have a higher score and 80% of the animals get infected. So these data provide compelling evidence that SSIs may originate from gut pathogens via processes that develop beyond direct wound contamination, and doping the gut environment with PI-PEG may represent a more evolutionarily stable strategy to prevent SSIs over escalating antibiotic use and further measures of intraoperative sterility. And thank everybody. That's it.
Thanks. So Dr. Alverdy,